Healthcare is confusing. Payer policies change, regulations are modified, reforms are proposed. We're breaking it down for you here on Inside Healthcare from Fulcrum Strategies. Hello, everyone, and welcome to Inside Healthcare from Fulcrum Strategies. I'm Matthew Handley, and joining me is our President and CEO, Ron Howrigon. Ron, hello. How are you, sir?
I'm good. I hope you are as well.
I am. Can I call you world famous now that you've been on a Sunday morning news magazine?
Hey, I got my 15 seconds of fame, so I think I'm going to go ahead and keep my day job and not worry about autographs. So,
Well, let's talk about that interview, though, because it was
Mhm.
for a very noble cause.
Yeah.
CBS Sunday Morning was doing a story on insurance denials, and they interviewed Tracy Hurley, who we've spoken to before
Mhm.
on
Yep.
previous iterations of this program, as well as her late husband, Dr. Dan Hurley, who passed away back in 2023. I want to play a clip now from that CBS Sunday Morning story, and we'll talk about it after this.
Health insurance companies know that 5% of their members account for 50% of all the cost. So I have this huge financial incentive to make their lives as difficult as possible.
Ron Howrigon, now a consultant, spent 2 decades working for health insurance companies and says the business model is unlike other industries.
The more your customers use your product, the less money you make. Your incentive is to keep them from using your product.
How often do insurance companies refuse to cover the cost of medical treatments? Well, it's hard to tell. Health insurance companies are only required to report denial data for plans purchased through healthcare.gov. A CBS News analysis of about 1.3 billion federal health insurance claims across 3 years shows that in 2024, insurers denied 19% of in-network claims. But for the biggest insurer, United Healthcare, that was a steep drop from the preceding 2 years, when it denied as many as 1/3 of its federal claims. While it did not provide data to support it, United Healthcare says that across all its plans, their initial denial rate is 10%. They also point out that when employers are self-insured, the plans they choose for their employees dictate coverage decisions.
Again, that was from CBS Sunday Morning this week. Ron, it's interesting to me that this follows a story from 60 Minutes about 2 months ago. They were talking about some of those employee plans where the self-funded employers get to choose what's covered. They were talking particularly then about expensive gene therapies.
Yeah.
But here we're talking about, in the instance of Dr. Dan Hurley, CT scans, MRIs, PET
Right.
scans.
Right.
We in the industry understand the basics here of why they don't want people to get care. It costs them money. They make money, as you said, when we don't use that care. It's almost like there's not really a real solution to this problem. I mean, what do you think? What ought to be happening to make sure that something like this gets corrected?
Well, I think at the fundamental level, the benefits of capitalism are that you get the behaviors that you want, that you reward. And in most industries, those behaviors are also good for the consumer. The reason why the laptop computers get smaller and faster and better and cheaper is because that's the way Apple and IBM and everybody makes profit. Is the consumer wins because they make a better product. Healthcare is on the opposite. Okay, the seller of the service or the insurance company makes money when we don't use it. So if you want to get different behavior, you've got to reward them differently. You've got to pay doctors. You've got to have insurance companies make profit for keeping people healthy. If the best way for United Healthcare, and I'm just picking them, Cigna, Aetna, Blue, the rest of them are all the same. If the best way for them to make a decent stock price was to improve the overall health status for their members, that's exactly what they would do. You know, if they got paid better for the average weight loss of their population, which we know improves health, they'd be providing GLP-1s. They'd be paying your gym membership. They would buy you healthier food. The problem is that in this situation, the financial incentives are what are bad for the consumer, unlike, cars or laptops or anything else. So that's got to be the fundamental change, or there's got to be better oversight or regulation on it to keep them from doing bad things.
Well, and Tracy Hurley had mentioned it. Dr. Tracy Hurley had mentioned it in the segment too, and we've talked about it before on this and previous iterations of this program, that if we were to make denying care a medical decision, therefore subject to malpractice, making sure that even things that you would think would be common sense, that an ophthalmologist shouldn't be reviewing prior authorization for an MRI,
Right.
that might go a long way as well to ensure that patients are able to get the care that they need, and doctors feel like they're able to provide the care that they think that their patients need.
Right. Yeah, you and I have talked about this in previous podcasts. Why are factories a whole lot safer than they were 100 years ago? Because of OSHA. Now, it's not because industry suddenly said, I don't want anybody hurt on my factory floor. It's because the penalties from OSHA, the cost of doing business, if you run an unsafe factory, are more than what the profit you would make by not putting in the safety procedures. Again, if it was as simple as saying when an insurance company medical director signs off on a denial or fails to authorize a PET scan, that they have to follow all the responsibilities of the treating physician, be in the specialty, be licensed, chart what they're doing, review medical information, and be held responsible for malpractice if they're wrong, it'd go away, because suddenly it wouldn't be profitable anymore to deny care. It would cost too much. Again, I use the OSHA example because it's a perfect analogy of why things got safer, because it was too expensive to not be safe.
And I think we want to be clear there is a time and a place for denials. I know what's the term du jour that I hear a lot from at least conservative Republicans is waste, fraud, and abuse. And there is a subset of physicians, unfortunately, that would engage in something like that. But as I mentioned on LinkedIn, and I saw you were posting on LinkedIn this weekend as well, the vast majority of physicians don't fall into that category. As we've talked about before, there's so much less of an incentive to get into medicine at this point. The amount of time you got to spend in school, the amount of money you got to spend to go to school, the fact that when you come out in a lot of these specialties, for example, pediatrics, you're not getting paid a whole lot.
Oh.
You're overworked if you're in an ER. There's not the incentive to commit fraud that I think the claim is, at least from the insurance side. And instead we've put all these hoops administratively that makes it even less enticing for people to join the profession. And that's going to cause, we're already facing a doctor shortage here in the next couple of years. That's only going to exacerbate it.
Yeah, well, just look at some of the numbers they quoted just from the ACA plans. Okay, the recent numbers across the board, across all carriers, 20% denied. Do we really believe that 1 out of every 5 physician decisions is wrong or wasteful? And then you look at the United numbers, 1 out of 3. Those numbers alone, if we were arguing about a 2% denial rate, I'd say, you know what, the payers are probably right. In any profession, there's probably a 1-2% where it's not the right thing to do. 1 out of 3 or 1 out of 5, that's just ridiculous. That's just profit seeking on the payer side. There's no way 1 out of every 5 doctor decisions is wrong.
And it's not just denials, it's denials, it's down coding. That's another one we're seeing a lot of right now, particularly with high level E&M codes. And just the amount of administrative burdens that, to put it in a PG term, it's just crap for the doctors to have to do, rather than actually taking care of patients, actually making patients healthier, which would bring down the cost overall.
Well, you looked at the one segment with Dr. Potter when she talked about she has 2 full-time people who do nothing but chase down prior auth and approvals. And the patient that they showed that had to come back for a second surgery, a whole second dose of anesthesia, because they couldn't get it prior auth with the first surgery. That's the stuff. To me, that's the waste, fraud, and abuse. That's the healthcare cost that we should be easy to get out of. I'm not going to say optimistic. I'm still at least a little hopeful that somewhere politicians will jump onto this and will pass a law on this prior auth stuff. I think it would be massively popular for the population, and I'm hopeful that it's, and we've talked about this before, that that scene from the first Ghostbusters movie when he's in the mayor's office and he goes, Lenny, if we're right, you will have saved the lives of millions of registered voters. And his eyes light up that maybe we'll get Congress to go, hey, you'll make fans out of millions of registered voters. I don't care what their motive is. Let's just fix this.
Well, I'll be the cynic here because I don't think it'll happen during this administration. We had Robert F. Kennedy Jr. last year meeting with an unnamed group of executives from unnamed insurance companies saying they were agreeing to lower prior auth, at least on Medicare Advantage.
Yeah.
But there was no guarantee for any of that. It was a kind of a handshake sort of thing. And again, we didn't know who was involved in that meeting. Unfortunately, it's not a priority. And even I have hope that at least some of the physicians that are in Congress right now that they would make it a little bit of a priority, but I have yet to see that as well.
I think, well, it's that old saying, what's the difference between an optimist and a pessimist? Experience. I think experience is on your side. That's why I said I'm not optimistic. I'm guardedly hopeful. There's 21 physicians in the House of Representative. There are 4 in the Senate. To me, that's 26 people who should be riding this like crazy because it's their profession and it's easy to patient protection. But we'll see. I think let's put it this way. I would not bet money with you and you couldn't give me enough odds to bet on my side. I'm just trying to be a little hopeful.
Well, that's fair. Let me ask you this one last question before we go today, because I'd mentioned the solution that Dr. Tracy Hurley had suggested, making prior authorization decisions, denials, the practice of medicine. And that's something that we've talked about a little bit before. What are the practical outcomes of that? If we were to implement something like that, what would have to happen now on the insurance company side, and what kind of results do you think we'd see on the patient provider side?
So the results would be almost instantaneous. If they passed a law that said that a physician signing off on refusing a prior auth or on a denial had to follow just the same responsibilities and accountabilities of physicians. Practicing in your state, you're licensed in your specialty. You have to create a chart, an EMR chart that documents your thinking. It's what the ordering doctor had to do. And you can be held responsible for malpractice. This problem would resolve itself almost overnight because it would be so costly, first of all, to go through the process. There'd be no more click and deny every 1.2 seconds. Okay. You can't chart that fast. And the plaintiff's attorneys would be lined up at the door. So the first time Dan Hurley gets a PET scan denied to start a marker on his cancer, there would be a plaintiff's attorney suing that doctor and their company for millions of dollars. And that's what would go away. It would go away almost overnight. And it's a simple solution. Now, I would argue that the stuff that really is waste, fraud, and abuse, that could be handled by the payers almost like an IRS audit. If they see that Dr. Matthew Handley is ordering an MRI on every one of his patients and he owns an MRI machine, then audit that. Look for that. It'd be like if I tried to say on my tax return that I gave away $1 million of charitable contributions and I didn't make $1 million last year. I'm going to get audited. Okay, that's going to look funny. So, but the practical implications is that kind of stupid denial stuff would go away almost overnight.
Would that require regulation? Would it require a rule from HHS? What would be necessary to make that change?
The easiest thing would be regulation. The easiest thing would be federal regulation. It can be done at the state level. The problem at the state level, you got an argument whether the self-funded customers are governed by it. So it would only protect about a third of the patients. But the easiest thing to do would be to regulation and make that definition. Because once you change that definition, then, malpractice and all those other rules apply because what the payers will say. And I used to say it when I was at the payers. We're not practicing medicine. We're not saying you can't have it. We're just saying we aren't going to pay for it.
Right.
Once you get past that, then game over.
One follow-up that's come to me as well, thinking about these self-funded, because that was mentioned in the story with United's statement specifically that self-funded employers get to pick coverage decisions. How much of that is the self-funded employers relying on United's policies to do prior auth, and how much of that is actually decided at the employer level?
So this is one of those things and the producer called me about that. And I said, technically, they're right. The self-funded employer is the one who's actually paying, and they can choose to pay for anything they want to. They are using United Healthcare to decide. Ford Motor Company doesn't know whether a PET scan is medically necessary. They contract with United to do that for them, and they are trusting that United is doing a good job with it, or Cigna or Aetna or whoever. The analogy I used with when the producer asked me about that, I said, to me, that defense of it's not us, it's the self-funded employers, is about as valid as the post-World War II German defense of I was just following orders. No, you don't get to do that. You knew what you were doing. And United knows that that's crap. It's just a PR defense.
Well, with that, let's end it there today. We'll talk more about this, and we'll have the whole story, the whole segment from CBS Sunday Morning linked in the show notes for this program. I'll also make sure we link our previous conversations with the late Dr. Dan Hurley, as well as the conversation we had with Dr. Tracy Hurley and his Dr. Hurley's family as well. Yeah. Those will be in the show notes of this week's episode. We've got a lot planned for you on Inside Healthcare this year. We look forward to talking to you more. And Ron, thanks for talking to me today.
Great. Thank you.